Hi everyone, Jennifer Blevins Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today we're going to talk about the main 5 things you need to follow in order to do proper incident to billing. Medicare CMS has their own guidelines when it comes to incident to billing. Other insurances, commercial payers will also have their own guidelines unless they specify in their provider manual or billing guidelines that they follow Medicare. Therefore, we're only going to go over Medicare's guidelines today. But if this is something you want to practice in your clinic with incident to billing, I recommend doing a ton of research, making sure that you're following all of the regulations and the requirements very closely to a T, or you could be subject to takebacks or other penalties that could be even larger. Again, this is just an informative video. If you are wanting to learn more about this, you want to practice this in your clinic, again, please do your own due diligence and don't just use this as your only reference. The first guideline you have to follow when it comes to Medicare's incident to billing guidelines is it can only be billed under professional services. So incident to can only be billed for like E&M codes, things like that, diagnostic imaging, labs, EKGs, things like that that have kind of their own category of billing actually have to be billed under the rendering provider who is performing it or who ordered it. So again, make sure that you're following these guidelines because it's only for professional services. Number 2, incident to billing can only be performed in a non-institutional setting. The definition per CMS is non-institutional would mean anywhere but a hospital or a skilled nursing facility. There are some other gray areas such as like home health and things like that. So if those are areas that you're going to be practicing and you need to know more, again, do your own research. So the first 2 guidelines, 1 is you can only do incident to billing for professional services. 2, it can only occur in non-institutional settings. Number 3, and this is very big and a lot of people miss this, the incident to billing can only occur for follow-up visits only. It can't be a new patient. It can't be for a new problem. The whole purpose behind incident to billing is for the patient to actually see a designated provider, usually an MD or DO, and they diagnose them, they put their plan of care together, and then it's the role of the designated professional provider under that supervising physician to follow through on that care plan. So that means that the care plan is already set into place because they've seen the MD or DO recently, and the mid-level or whoever is being billed as incident to is actually seeing the patient, following what the MD DO put out, and making sure that everything is established already. If the patient brings up a new issue or concern, if the patient, if something was discovered on the patient during an exam or something that's new that wasn't seen by the doctor previously, that has to be billed by the actual provider who is performing that service. So if a PA was seeing a patient, a cancer patient, let's say, and following up on how they're doing with their cancer treatment, and it comes back that they are complaining of pain in a new place or some new symptoms that they weren't previously experiencing, that would need to be billed out under the actual physician assistant and not under the actual DOMD who originally saw the patient and as incident to. This is where things can get really gray and really difficult. And that's where a lot of people, I think, get hung up and things can get really confusing or, like I said, messy and cause some problems. The 4th thing is that the person who is billing incident to that mid-level provider or that ancillary provider in the practice actually needs to be directly supervised by a doctor on site. They don't necessarily need to be in the same room, but per Medicare guidelines, they actually have to be in the same suite. They have to be readily available to come in if something were to be going on, to be consulted if something were to come up. And that is where also a lot of people miss the detail. They think that because the supervising provider is available over the phone or text message, or they're in a suite next door or a surgical suite on the bottom floor, that they still qualify. And that is not true per Medicare guidelines. They actually have to be present in the same suite, so in the same clinic, so that they are readily available physically, not just through voice or through text message. There are varying degrees of this with different insurances. So again, check your commercial payers if you want to bill incident to, because they may have different guidelines that you can follow. But again, that could get really confusing for your staff and your mid-levels on who requires what. So, that's one reason why I'm not a huge fan of billing incident to, but it can work well if you follow all these guidelines. The other thing that people don't realize, and this is going to be our big thing to remember, is that the supervising physician has to actually be actively involved in the patient's case. So they can't just see the patient one time, establish a plan of care, and be done and pass it to somebody who's going to bill incident to and see the patient. No, this doctor has to be readily involved with this patient. A lot of people have like a policy in their practice when they follow incident to, saying that the patient needs to be seen by the provider like every third visit or every fourth visit by the actual doctor, the MDDO, just to make sure that they are showing that they're actively involved, that if anything new comes up, it's documented, plan of cares are associated with it, so that when they are seen by the designated mid-level or other associated provider, that they know exactly what to do, and there's no question whether the MD or DO is actively involved in that patient's case. So that's another thing. It's good. I recommend having just a clear-cut policy across the board in the whole clinic that patients have to be seen every 3 to 4 times by the MDDO if nothing new has come up between their last visit with the doctor to their next one. Obviously, if there's something new that comes up and they need to see them, you would work them in, but just standing orders would be every 3 to 4 visits. And then the last one I want to talk about is that both providers, both the doctor, the supervising physician, and the delegated mid-level or associated provider who will be treating this patient off times when the doctor isn't, both have to be employed by the same group. And that is really important, because if the provider is not, and they're seeing the patient and they're not a regular employee of that practice, that group, then that changes what kind of billing it is. And we could go into a whole nother video for that. And I do have another video for that. However, you have to make sure that both the providers are in the group, employed by the group. So if it's a sole provider, a sole proprietor, the doctor would be the sole proprietor establishing the care with the patient, and then the mid-level or whomever would be taking out stitches, maybe as a medical assistant or something like that. Whoever's working within their licensure to be able to bill incident to also has to be employed by that sole proprietor and be an employee, or be an employee of the group. So they both have to be. Also, something I didn't mention is that the doctor that is the director of the patient's care, the direct supervising physician, has to be credentialed with the insurance as well. So there is always a question about whether the mid-levels or the designated provider who will be billing incident to under that supervising provider has to be credentialed, and it doesn't look like they have to be credentialed. However, if they are a mid-level like an NP or a PA, and something new comes up, or they order diagnostic testing or labs or something like that, they would have to bill under themselves. And if they're not credentialed, that could cause a lot of issues and losing some revenue in your practice. So I always say you should have everybody credentialed, enrolled with the insurances in which you bill. And if you want to do incident to billing for your mid-levels because you want to get that 100% reimbursement instead of that reduced 80 to 85% that they only pay for mid-levels, that's completely fine. Make sure they're credentialed is my recommendation. And also that everything is spelled out. Everybody understands the guidelines very closely and they follow it to a T so that you're not having any billing violations and you're not going to get in trouble. If you have any questions or comments about this, please leave that in the comments below. Smash the thumbs up button if today's video was helpful. Subscribe to my channel if you haven't already, and please share this with your colleagues whom you feel would benefit. I appreciate your support, and I'll see you next time.